Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find previous episodes on Apple Podcast, Spotify, Google Podcast, and Stitcher Radio. Kawasaki disease must be one of the most interesting and mysterious diseases that we treat. While the classic presentation of KD is not easy to miss, there are so many different variations in the signs and symptoms that children have, and so many ways that they respond to treatment that you can spend an entire lifetime studying it and still be puzzled about making the diagnosis in a child with fevers in the emergency department or in selecting the right treatment for a specific child. For a long time, the American Heart Association has created guidelines for the diagnosis, treatment, and management of Kawasaki disease. But just this year, for the first time, the American College of Rheumatology and the Vasculitis Foundation released their own guidelines for the management of Kawasaki disease. Unlike the AHA guidelines, the ACR guidelines focus on situations where rheumatologists typically get involved, such as in treatment-refractory, severe, or complicated KD. With me today to discuss these guidelines is Dr. Mark Gorelik, the lead author of the ACR Vasculitis Foundation's guidelines. Dr. Gorelik is an assistant professor of pediatrics at Columbia University Vagelos College of Physicians and Surgeons. He's a pediatric rheumatologist and allergist immunologist. His research focuses on vasculitis, including Kawasaki disease, and on immune dysregulation. We'll discuss everything from the mysterious triggers that may cause KD, the use of therapies such as IVIG, steroids, infliximab, and anakinra, and compare multisystem inflammatory disease in children, or MIS-C, a condition very similar to Kawasaki disease that is triggered by SARS CoV-2. Hope you enjoy the show. Hey, Mark, welcome to the show.
Thank you very much for having me. I appreciate it very much.
So, Mark, paint a picture of what a typical child with Kawasaki disease looks like. Because, I feel like this is one of the most very dramatic diseases that we take care of in rheumatology. They present often very ill, and we can make them better so quickly afterwards. So, for listeners out there that have actually never seen KD, can you tell us what it looks like?
Sure. That's true. And I think that Kawasaki disease is different in many ways from, most of the rheumatic diseases that we're used to dealing with, because they tend to be chronic diseases that have this sort of oftentimes chronic prodrome or chronic presentation, and then they remain chronic and they remain diseases which require long-term therapy. And Kawasaki disease is really an acute disease. And you could say that there are, without getting into the sort of the technicalities of things, you could say that there are sort of two big ways that Kawasaki presents, which is, and I'm trying not to be facetious about it, but it's textbook and not textbook, basically.
I like that. I make it simple.
Right. So, textbook Kawasaki disease is something that every pediatrician sees many times in their residency. And that's because it's not as rare a disease as thought. If you're a pediatric resident in a typical, children's hospital in the medium or large size metropolitan area, you're going to see one of these once a month. And the presentation is basically, a child who is somewhere between 6 months and 6 years of age. But usually, again, textbook would be, smack in the middle of that, one or, probably around 18 months. Say, and with fever. And one thing that's not in, any guidelines or any sort of objective literature discussion of Kawasaki disease is how, miserable, or in pediatric speak, fussy these kids are. They tend to be very, irritable. They look sick.
Often the parents are just as irritable, right? Like, I mean,
I
these
think
kids,
frazzled. Yes, you
right?
could say.
Yeah, I think that's such an important point. These kids are miserable, and the parents have been dealing with them, for several days by the time they make it to to usually the emergency department.
It's actually a clinical clue in some senses because, there's a lot of times where kids might have other things, fever from a urinary tract infection or, fever from, pneumonia, etc. They're not going to be this degree and this type of irritability. It's pretty useful to think about when you're thinking about this diagnosis. And also the irritability tends to just disappear, within the few hours after they get the IVIG. And so the patients tend to look and feel, it's almost a marker of the disease itself. And then in the books, the other criteria are, having fever for 4 days or more, having then some of these signs and symptoms that, if you're talking about a textbook case, they would have conjunctivitis, mucositis, which is sort of a difficult one to get your head around sometimes because a lot of kids who are dehydrated have a little bit of quote unquote chapped lips and other things like that. Interestingly enough, the mucositis, the sort of oral mucosal inflammation in Kawasaki disease, when it's biopsied, is a vasculitis of this very small vessels in the mucosa. You can see little, so it is not just sort of erythema or like one might see in toxic shock, but it's a really an inflammatory process.
Yeah, the typical strawberry tongue, right?
Right, and that's a sort of a papillitis, right, of the tongues and of the taste buds, obviously. And then the same with the conjunctivitis, typically associated with uveitis. It's not just red eyes; it's an inflammatory process. Extremity changes where there might be extremity swelling, palmar erythema of the soles of the feet, and then sometimes, and harder to sort of appreciate sometimes, is lymphadenopathy. And so those are all sort of your key features. And then oftentimes after several days go by, 7 to 10 days go by, these patients then start having peeling of their hands and feet. And then sometimes when you haven't, the diagnosis is not textbook, that kind of feature can make you realize that, you've had a diagnosis of Kawasaki disease. And so the other side of that is sort of the not textbook cases of Kawasaki disease, where there's so many case reports and unusual clinical presentations. So those could be, in the under 6-month-old group, sometimes only one of those features might go along with fever, such as fever and conjunctivitis. In some cases, in that under 6-month-old age group, just prolonged fever can be a presenting sign. So it can be, very difficult to make that diagnosis. Shock. So in some, there's a Kawasaki shock syndrome where patients might present with shock and then manifest some of the signs and symptoms of Kawasaki disease, and sometimes none of the signs and symptoms of Kawasaki disease, and have impressive coronary aneurysms. And so, based on that, when kids have unexplained shock, thinking about that diagnosis is something to, put in the back of your mind.
Yeah, when you mention that, it sort of strikes a similarity to adults that have giant cell arteritis, where typically they have several signs and symptoms associated with giant cell arteritis. Certainly systemic inflammation and sometimes fevers, but sometimes systemic inflammations and fevers is the only presenting manifestation, and physicians need to consider. Oh, should we do a temporal artery biopsy? It certainly seems like a similar thing in children as well.
Yeah. Yeah. And I think that the vasculitides in general are often challenging because of that, that kind of presenting picture. And then in some cases, very strange, things have been sort of reported in the literature, like what looks like a retroperitoneal abscess or a phlegmon, which is just sort of very impressive lymphadenopathy with, surrounding, erythema and edema, can be Kawasaki disease. And obviously these things are much harder to sort of make the diagnosis. And I'm sort of straying away from, what you would call, quote unquote, the diagnostic criteria of this disease. But there are presentations that don't even fit the diagnostic criteria, but are Kawasaki disease.
Yeah, and I guess you can tell that they were Kawasaki disease because of perhaps the peeling or the development of aneurysms?
Yeah, in some of those cases, and in some of those cases, the main feature, which is the sort of the unusual feature that's coming along, is drowning out some of these other more subtle things, but looking at the patient a little more carefully might bring, some of those other clinical criteria to light in your exam.
Yeah. And tell me a little bit about, you sort of hinted at it, the aneurysms. How bad can these get? Like, is it a problem for these children to develop aneurysms?
Well, sure. Yes, yes. So aneurysms, obviously, in the age of IVIG, the frequency of aneurysms is much lower now. So with treatment still, about under 5% of treated patients will still develop some degree of coronary aneurysms. Before the age of IVIG, it was, somewhere around a quarter of patients or so. And in many cases, but certainly not all cases, these will be persistent throughout life. In some cases, and probably, a moderate majority of the cases, these aneurysms sort of remodel over life and they disappear, especially if they're not, gigantic to begin with, and so they're graded in terms of their sort of score. And in pediatrics, there's a Z score, just like there's a Z score for a lot of things. There's a Z score of how many standard deviations the aneurysm might be, bigger than the normal size. And when you get to sort of the giant-sized aneurysms, which are, only in a small minority of cases, those tend to be persistent and can put a child, certainly requiring anticoagulation for life, increase need for various cardiac monitoring for life, increased rate of adverse, cardiac events later on in life, etc. And in the extreme scenarios, these patients in some settings, can have MIs and things like that.
I've heard it said that it's one of the most common causes of acquired cardiac disease in children.
That's right. So, in the olden days, and I don't know how old, but in the old days, strep throat obviously was the, number one cause of acquired heart disease in terms of aortic, valvular disease. And since we have gotten more of a handle, although, there are still patients who are unlucky in that as well. But since we've gotten more of a handle of that, now it is Kawasaki disease, which is the, number one cause of acquired heart disease in children. And that, it sort of generally means the coronary aneurysms and issues related to that. And obviously, if you have an aneurysm, you are going to have, disordered blood flow in that vessel. And then you're going to kind of go down that Virchow's triad problem where you might have a clot or something in that vessel. And so that's a major part of the morbidity of this disease.
Yeah, that makes sense. So it's very important to recognize it and then treat it appropriately. Before we get to the treatment, I want to better understand why guidelines were needed. So, as I was training, I remember using the American Heart Association guidelines for the management of KD. So why did the American College of Rheumatology and the Vasculitis Foundation decide to have these guidelines for managing KD?
One thing is to stress is that the American College, the cardiology guidelines are fantastic guidelines, and we definitely had no intention, and I think we sort of articulated that in these, that there's no desire at all to supplant those, and it's not possible really to supplant those guidelines. They're so comprehensive and well done. The goal is that for rheumatologists in particular, we tend to be the ones who are consulted in the unusual situations, in the situations where there's refractory disease, where things are just not your typical scenario. And so for that reason, there really isn't a lot of guidelines or data even, or, literature, so to speak, that is very concrete for, a practicing physician, what to do in those kind of more unusual circumstances. And so that was the reason, to kind of add as an adjunct to the cardiology guidelines. And, we also sort of included a couple of what we call like a good practice statement, whereas, just to reemphasize some of these things that are in the original cardiology guidelines, but in general, not to supplant those.
Yeah. So how should we treat Kawasaki disease? If we thought that a patient has all the classic features, they've had the fevers for 5 days, they have all the laboratory markers that are consistent with KD, what's the most important drug to give these children?
The central thesis of Kawasaki disease and remains since, it was kind of described a long time ago, and I feel almost embarrassed that I forgot her name, who is sort of the doyen of pediatric cardiology at Boston Children's, who sort of came up with IV or
Neuberger.
Dr. Yes, Jane Neuberger, who, yes, I've corresponded with her personally, so hopefully she won't be too upset. But yes, so those are her, her discovery of the, IVIG and its utility in Kawasaki disease. So that's the sort of central thesis for Kawasaki disease. And we still don't know how, really that drug works, but it's definitely really fascinating how it aborts basically in, most of the cases, both sort of the inflammatory process and the subsequent, coronary aneurysm development, for the most part. And that is, for people who like to talk about mechanism, etc., it's always it's sort of an endless source of fascination is how that drug is working. And then, back before Kawasaki disease, before IVIG, the drug that was sort of first in the armamentarium was aspirin, very high dose aspirin, really used for its anti-inflammatory purposes. And then IVIG came along, and the high dose aspirin remained in the guidelines as sort of a holdover. And subsequently, there have been really quite several studies which have looked at, do we really need high dose aspirin after IVIG? And the answer seems to be no, that having aspirin on the table for its, anticoagulative, anti-clot properties is useful, very useful and very important, because after, somebody gets Kawasaki disease, if they have an aneurysm, the aspirin will do a good job of preventing clot in that vessel. But high dose aspirin as an anti-inflammatory is not necessary.
Yeah, and I remember when I was training, like high dose aspirin is just astronomical, right? It's like a little 10 kilogram child getting 1,000 milligrams of aspirin divided, in several doses divided daily. I mean,
Right.
It's just crazy.
And and I think that there's no study that has really said it's worse. It's sort of has more adverse effects. You would sort of maybe think about it, but as there has been no study that has sort of suggested definitively that it's worse to do that, the guideline recommendation that we put forth was aspirin is important, the dose is not. And so whether you use high dose, quote unquote medium dose, which is really just slightly lower high dose, or your standard sort of low dose, 3 to 5 milligrams per kilogram aspirin, which usually amounts to sort of a half a baby aspirin or maybe a baby aspirin in a larger kid, is what is needed.
Yep. And then, I remember when I was training, residents would ask me, well, what about steroids? And I always used to tell them that no, steroids don't work for Kawasaki disease. And it's been sort of a 180 change where now we like seriously consider, the addition of steroids to some patients. How do you decide who benefits?
Right. And that is still in some ways, right, an open question, especially for, non-Japanese populations, because in the Japanese population, studies have been done to sort of, they feel can identify higher risk patients, and just, reminding the audience that, this is a disease that for genetic reasons probably is of most high incidence in the Japanese population, and then also in some other Southeast Asian populations. But the use of steroids has gone, like you said, quite drastically changed. And, there are certainly, even just within the last, 4 or 5 years, there would still be definitely people, and certainly some places who do a lot of Kawasaki work on the West Coast would sort of cringe at the idea that we might be giving, patients steroids. And I definitely, respect their views as well. And, there's lots of knowledge that goes into those. I think that at this point, it appears that the use of steroids in certain, patients that are, high risk, and again, I'll mention exactly what that is, but can reduce, the incidence of aneurysm later which is sort of the end goal. And it's very hard to know, though, and that's where the sticky part came in. And in kind of discussing these guidelines, this was a challenging issue because some folks, and I think quite rightly, said, well, if we don't know who the high-risk patients are, you're putting some people in a difficult situation because they may feel that they should err on the side of using steroids, whereas some other folks might feel confused about it. But in general, the high risk that we decided to use is sort of very conservative high risk. And that is, number one is being under 6 months of age. So for reasons that are still unclear, being under 6 months of age, and it also, the term high risk is sort of a loaded term because it's you would also get into this question, well, what are you high risk for? Are you high risk for refractory disease? Are you high risk for developing bad aneurysms? Are you high risk for both? Certainly, I think, and I tend not to be a pedantic kind of person, but I think certain kind of people would say, oh, well, what exactly are you talking about when you say high risk? So I'm just going to, preface this by saying that, I mean sort of high risk in the colloquial kind of term, that they may be either, refractory or, go on to develop severe disease, knowing that those are two different things and really need to be studied separately. But high risk would be, again, you're under 6 months, you may be more likely to not respond to IVIG initially, you may be more likely to develop aneurysms, more likely to develop giant aneurysms. So that's one group. And then if you've already got aneurysms at the time of the first echo, so, typically the first echo is about 7 days. It takes about at least 7 days to start developing an aneurysm in terms of disease. So typically, if somebody's had 5 days of fever and you get an echo at that time, most of the time they're not going to have an aneurysm, but they may, if they are going to develop it, will have one 2 weeks later. But if you already have an aneurysm, then that would be also putting you in sort of the high risk category. And so those patients get sort of a short tapered course of steroids, which is kind of tapered over 15 days. And that's based on the sort of Japanese literature. But, we still don't know a whole lot. And certainly steroids by themselves, for some reason, don't have that effect. They're not as effective like that. And so again, you get into that sort of fascinating question of why it is that IVIG works, why it is that, why steroids only work as an adjunctive. Obviously there's multiple mechanisms happening, going on to sort of potentiate this disease.
Yeah. So the role of IVIG in these patients is so dramatic, as you mentioned. Like, a couple of months ago, I was treating a child. Actually, Jane Newberger was the cardiology consultant that was helping to manage this patient. And she came into the ED, was so irritable. She got IVIG overnight, and she looked like a peach the next morning. It's so dramatic. But, unfortunately, not every patient is like that. And some patients continue having fevers after that first dose of IVIG. So what's the next step?
The next step is I think there is some equipoise there. And, our guidelines, so traditionally, the next step was, if there's another fever after 48 hours, the next step is to repeat IVIG. That is what our guidelines said. But even as those guidelines were sort of being written up, and I think that's something that might change, in the future, probably quite soon, things were sort of changing. And that was sort of a discussion. And I personally felt that there is so much equipoise in between giving somebody a pulse of steroids or IVIG, or even, low dose steroids for several days, that you could choose either. But the committee decided that we wanted to go on the IVIG route. So the IVIG route, because of its sort of mainstream repeat IVIG, because of the fact that it's been there for so long, is a reliable therapy. And most children who have not responded to the first do respond to the second. One of the things about IVIG in very, very large doses, you're talking about 2 grams per kilo when you're repeating that, is that you can get some hemolysis. And it kind of depends on the blood type of the patient. And some patients can be pretty, it can be quite impressive. And so I just recall, just a few months ago, a patient that, and again, a lot of these things, again, and we also try to identify this issue. A lot of things are family-based too. Families have input and families have worries and concerns of their own. And, because IVIG, repeat dosing of IVIG is so mainstream, a few months ago, I had a patient and we discussed this issue, and they had discussed with somebody else that's in medicine. And that other person said, well, no, the only thing to do is to repeat the IVIG because, that's tradition, right? It's like Fiddler on the Roof. But this patient did not respond to that second IVIG. And just, when we had the CBC after that second IVIG, that patient's hemoglobin was 6.7. And it's just sort of an example of how dramatic that can be sometimes and why, there are other modalities. So I tend to like to pulse patients with steroids. Some other folks tend to like to use infliximab, which is probably also a very, very valid therapy. And we don't know, there's still studies kind of showing this, looking at this issue, but I think all of those things are reasonable choices.
Yeah, I think that's great. And certainly that's when, rheumatologists should definitely be involved in the care of these patients. I find it so interesting. So in Boston, rheumatology and cardiology get involved with every patient with Kawasaki disease. And in some other institutions, it's somebody else. It's sometimes it's just general pediatrics. Sometimes it's infectious diseases. So it's interesting. But certainly when you're thinking about, somebody who's refractory, or you're thinking about using these immunomodulatory medications, then certainly it seems reasonable that at that time rheumatologists should get involved.
Sure. Yeah, no. And I think, one of the reasons that one of the patients that I really remember strongly, sort of a patient that really made me very interested in this, was a patient that I had when I was just, I think, starting as as a clinical rheumatologist, and was a little girl who had gigantic aneurysms of all of her coronary vessels, and was sort of in this situation where, and not only that, had fever for, maybe about 20 days or so. So she was sort of beyond the, that traditional, day that one would think, which is very, by the way, it's arbitrary. We don't, that there's a 10-day, tradition, again, another tradition issue where you have this idea that, before 10 days, you should treat with IVIG. And really that sort of came about from, early trials. And there really isn't, a definite time period. But this patient had long-standing febrile illness, and had missed, Kawasaki disease, also because she was young and didn't have all the typical features. And then was refractory to her initial IVIG as well, given the severity of her disease. And she was sort of on a monitored floor. There was this concern that at any moment she might, have a clot, or that she might require even heart transplant. But it gave some latitude to, aggressively treat that patient. And so, we treated that patient with steroids, also with infliximab and anakinra. And, because this is sort of an acute disease, we're not going to be treating this patient with any of these things for long term. There's really short-term immune modulation. And the anakinra was sort of based on, research that I, worked with somebody who has been looking at the mouse models of disease and the role of IL-1 in this disease, which is also very, very, front and center. And this patient, over the next 2-3 months, had complete resolution of those giant aneurysms. And so the question is, what do we need to do in those situations? What kind of therapies do we need to use? A lot of that does come from, studying mechanism and trying to understand the disease, I think. And so, the idea of using anakinra because IL-1 plays such a, central role in this disease, TNF-alpha plays such a central role in this disease, those kind of biologics can be very, very effective.
Yeah, it's really fascinating. I'm still so puzzled as to, what's going on in this patient. What is the trigger? Right, that causes this cascade, this inflammatory cascade that we call Kawasaki disease. Right? Is it a virus? I've read some studies that it may be some antigen from like
Northwest China. Uh-huh.
It's so fascinating, right? Because it's so dramatic, and I've heard especially in Japan there are epidemics of Kawasaki disease. So, is it something in the environment? It's still unclear.
Right. Well, I think that the recent history has sort of given us a view on that. The fact that we've had this disease after COVID called MIS-C, and incidentally, it really only seemed to be associated with the early strains of this virus. We are not seeing MIS-C right now with Omicron, by the way, which is almost as bizarre as the whole, last 3 years put together, right? But the fact that you have this disease, it's so similar to Kawasaki disease. And I really do think that there's a lot of mechanistic overlap. Just like Kawasaki disease, those patients, when they have conjunctivitis, they have uveitis, they have the same mucositis. when I've seen some of these MIS-C patients, some of them, not all of them, but a good 40-50% of them are textbook Kawasaki disease. And so, it makes you think that what is happening is a viral trigger. And in my opinion, and again, only my opinion, it's not one virus. It's multiple viruses. And these multiple viruses have the same kind of end immune response that can result in this kind of overwhelming event. And, maybe it's because there's sort of endothelial infection of these viruses, into vasculature that promotes, some cryptic antigen from being displayed or something like that. And then that epidemic nature of Kawasaki disease is also speaks to that, and is also really interesting because not only are there epidemics of Kawasaki disease, the response to treatment can vary depending on what epidemic strain happened. So, for instance, if there was one whole bunch of Kawasaki disease that happened, May of whatever in Japan, in 1978. 60% of those patients respond to IVIG, whereas 3 years later, another huge, bump, 95% of those patients respond to IVIG. And it really tells you there's something different about the two, etiologies, that they weren't probably the same virus or probably the same, the same antigen or something like that. So it's pretty fascinating stuff.
Yeah. It seems like MIS-C may be giving us some clues as to sort of the etiology of KD.
I think so, yes.
Yeah. For people out there, any tips in how to differentiate MIS-C from KD when you have a patient that's had, fevers and conjunctivitis?
Right. Well, one thing is, if somebody is meeting the criteria for Kawasaki disease, whether you think it's MIS-C or Kawasaki disease, they have Kawasaki disease. Does that make sense? You just treat it as Kawasaki disease. Number two is, again, this disease is really changing in its incidence and prevalence, and I think that MIS-C is going to be something that is rare, much more rare now. So we may be more going back to the situation where you get something like this, most likely just sort of by the incidence or the prevalence is going to be Kawasaki disease. But what MIS-C has that most Kawasaki does not is sort of this kind of shock phenotype, where there tends to be more of a hypotension that's sort of out of the range of the cardiac dysfunction that also we see sometimes in MIS-C. That kind of cardiac dysfunction also can sometimes be seen in Kawasaki disease, but almost, it's very, very rare, whereas it's very common. And then the aneurysms that develop in patients with MIS-C tend to resolve much faster than the aneurysms that we see in Kawasaki disease, for whatever reason that is, whether that is not a true vasculitis or whether there's something about the remodeling scenario that is different. And that's, hard to say.
Yeah. So stepping back, looking at the guidelines, these were published I think just in April of 2022. They're called the 2021 ACR Vasculitis Foundation Guidelines. So when did you start working on these?
I am trying to remember. I actually picked in, I think a third of the way into this, there was somewhat of a change in the guard because somebody had some personal family things that had come up. And so I got into it. But even then, it was a long time ago now. It might have been 2018 or something like that. It really, or 2019, it really took a long time to sort of put this all together, and took a long time for us to kind of get the agreement, and then, the final publication, etc. also took, some iterations. And I think, in part because we wanted to make sure that really all of the people who were in this field, and people who might be, say, authors on the cardiology guidelines as well could join us, because that would sort of add to sort of the knowledge base that was putting together these guidelines. So all of that took a long time. So longer than I would have anticipated, and longer than most people, I think, thought was going to be the case.
I've interviewed several authors of ACR guidelines, and I think every single one of them says that it took way longer than they ever expected. So, it took a long time to put this together. There were a lot of people, like the author list is huge. So what's next for these guidelines? Like, is there a plan to update them at some regularity in the future?
I don't know that there's a definite regularity plan, but I think that the idea is that this is a living document, because we're in an era now where knowledge is changing and that changes practices quite quickly. And, I think if there are certain changes that need to be done, those will be sort of updated. So for instance, the whole question of repeating IVIG versus, pulse doses of steroids, etc. The other thing, even though it's not exactly what you asked, but I think the other thing I wanted to mention in this is that there's sort of philosophical thing about guidelines which is that how much you should hew to them, how much you are expected to hew to those guidelines, etc. Because there is all sorts of complications in here, with legal complications from insurance standpoint, where if you're doing something that's quote unquote not by the guidelines. And I think that the other thing that we try to sort of stress a little bit in this is that there's more guide than lines, and that physicians should use their discretion and try to take this as advice and help, rather than a rigid set of rules that they must follow.
Great. Sort of in ending, what do you hope that we learn over the next few years about Kawasaki disease? For people that are in training or interested in doing research, like where should we focus our energy in terms of Kawasaki disease?
There's a couple of things. One of the big things is, what is the status of the vasculature after an aneurysm has resolved? So, you have, or it really hasn't resolved, but it's sort of remodeled. You have, a vessel which is initially appears to be injured and has an aneurysm or dilated, and then over the next several months, in a substantial proportion of patients, will remodel back to normal. What is the status of that? Is that endothelium healthy? Is it not healthy? I think that's a question. How can we sort of promote, if it is a healthy vessel that returns? How can we promote that? How can we harness that remodeling in patients who, for instance, still have giant aneurysms and still are on, daily anticoagulation? Can we sort of turn on that remodeling again and then turn it off? I think that those are sort of maybe long-term thoughts, but they go along with the sort of study of vascular remodeling that we know about these things in terms of stents. Stents can sort of induce intimal hyperplasia in vessels, and all the study of intimal hyperplasia, remodeling, vascular inflammation is sort of all related to this. And so it's also not just what we can learn about Kawasaki disease, but what Kawasaki disease perhaps can teach us about other vascular inflammatory processes.
Fantastic, Mark. This has been a wonderful conversation, and thank you so much for your insights, and thank you so much for leading, this huge guidelines. I'm sure that was, a lot of work.
I only had a small part in this, really, honestly, and I appreciate everybody's, Sharon Chung, the rest of the committee, who, and all the ACR folks who helped on this were, it would certainly, if any one of those folks was not present, this thing would not be completed.
Great. Well, thank you so much, and thank you for your time.
Thank you.
Thank you all for listening to our show. Don't forget to rate and subscribe to our podcast. Could you do me a favor and share it with at least one of your friends? Don't forget to follow us on Facebook and Twitter at ACR Room for updates that you won't want to miss. Until next time, grab the IVIG, and as always, please stay healthy.